What Frank taught me is that the most important thing to look for, Frank, seriously, is a change from a baseline of behavior. So anytime there is any kind of deterioration, change, new onset of a new set of behaviors or symptoms, that's the time to consider, is there psychopathology here? Is this the new onset of illness? If it goes beyond 2 weeks and you don't have a good environmental precipitant, Dr. Fisher talked about looking at antecedents for behavior changes. If there's not something obvious that has resulted in that change, and the symptoms or signs or change or deterioration last longer than, they're more than transient, then I think a psychiatric referral or referral to a behavioral specialist or some mental health professional is a good idea. I agree with you, a lot of treatment of people with dual diagnosis is done by non-psychiatrists. It has to be. There are just not enough specialty people working in this field, so much of it is done by psychology, by internists, family physicians, et cetera. I don't know if anybody else wants to respond.
I just wanted to add to that. For an individual who's seeing, say, an internist once a year, and you suspect, or there may be something going on, but you're not sure, I would suggest you rely on the care providers for information and input. If the person lives with natural family, mom and dad, if the person lives in a group home, the group home providers, those who know the individual the best. So you can find out what that baseline behavior is, because the individual may not have the expressive skills to inform you of that. So it's very important to rely on families for input. If not living with the natural family, then in an aggregate care setting, the staff that know the person best, not necessarily the person in charge of the group home.
I just wanted to add two things. One is we see a lot of individuals where we do our behavioral interventions and continue to see, erratic behavior periodically. It's an individual that's in right now clearly has behavior that when we disrupt he makes erector things and he makes things out of Legos, and when those get disrupted, that's a real trigger for his behavior. But there's more to it in terms of once something like that happens, he has explosive behavior to the point of he'll destroy the thing himself. So behaviorally we could correct whatever was the trigger, but his behavior doesn't shut off at that point in time. That is something that almost always needs to be dealt with medication. The other thing is just if it's going on for a long time, most of the people I see end up, seeing either a developmental pediatrician or a psychiatrist as well, and we try to coordinate our activities so that we make a behavioral manipulation or try something while the medication is held constant and vice versa, so that one thing is done at a time and we can figure out what's working and what's not.
I think the other thing is to look at the company that it keeps. I think very often we focus on a behavior and miss the surrounding ambience of symptoms. And really, most things don't occur in a vacuum. And what is the nature of those other things out there that are going on at the same time? Good example, like somebody who becomes manic. The rates of target behavior is going to escalate dramatically. And I use a lot of the data that Wayne collects to monitor an onset of psychiatric illness. You look at it, all of a sudden it jumps from rates of 3 times per month to 600. And to do the same with treatment. So I think if you got somebody, if you get access to information and you get access to people like Rob was saying who know that person, that's the best place to start. And again, something that does, most of these psychiatric diagnoses have durational criteria. I mean, they're arbitrary, but they're there. So something lasts a week versus 2 months versus 6 months for some psychotic disorders.
The questions that you would ask the parents or other care providers about the baseline behavior would be the same kind of questions you would ask a neurotypical individual. You'd ask questions about sleep patterns, because that's indicative, could be indicative of something. Eating patterns. Is there any change in engagement of usual pleasurable activities? All those three things are kind of indicative of, could be indicative of some affective disorder, either mania or depression. But you need to rely on the family to get that information, or other care providers.
I would say that the more likely, the higher functioning of the individual, the more likely it is that the presentation is closer to a typical presentation of psychiatric illness. as opposed to lower functioning individuals. And most primary care physicians have sort of a comfort zone of where they're willing to go. And because of the shortage of really skilled psychiatrists, that's where you have to start. And it's important for them to use that best information, particularly for the higher functioning folks. Beyond that, it gets very tricky. Steve, and then we have...
I was going to say, and family history. So that an individual with an intellectual disability who is in a family where, you know, there's a history of bipolar disorder or a history of depression, and you are more likely to look for those types of symptoms, see if they've responded to a particular intervention, that can be helpful.
And maybe I'll finish with this question and restate the obvious. The obvious model that we use for work in this area is the model of pediatrics or child psychiatry, where we have an identified patient. We often have the historian who is not the patient. Typical mainstream psychiatry, the patient comes and gives us the history, tells the story, and we do an examination of the patient. This is like pediatrics or child psychiatry, where we have the patient who is identified, who can give some history, but then we have primary historians, are often parents, siblings, caregivers. One of the things I learned at the knee of Dr. Mentalacino was the importance of attending to both of those constituencies, spending time with the historians, but also spending time examining and interacting with the patient to get the full history.
Here's a question that ought to generate some comment. There have been other types of treatments recommended for autism, such as diet therapy and chelation treatments. Can you please comment on the effectiveness of these treatments?
Well, I think that there's several questions embedded in that one. One is there evidence that those things are effective? And what is the evidence? And I think one of the problems with the way we study things is we look at group design projects. And so if 500 patients or kids are given the same intervention, we look at who improved and determine whether something's valuable. And I think what that tends to do is knock out the outliers, the people that are dramatic responders, or the people that got dramatically worse on that. So I think when you look at all these studies, you have to kind of look at it from that kind of perspective. Is it truly looking at what the questions are actually being asked? I think the other is that there's not a lot of evidence for some things. Chelation can actually be dangerous for some individuals. So I think most of the recommendations are that may not be an effective treatment, but there's always somebody out there that might respond. I think to apply that across the board might be dangerous. Some of the dietary interventions can be quite difficult. You know, a lot of parents have put their children on gluten-free diets and casein-free diets, and the assumption that they're indirectly or directly tied to autism. They're very difficult to follow, and I think you got to look at the practicality from the parent's point of view. Now, some can be effective. There are individuals with celiac disease who also have autism. And by treating the celiac disease, you may improve some of the symptoms of autism. But whether one causes the other is something that's going to be tough to establish. But I think I would look at anything that's promised to cure autism, be a little suspicious of, and get the evidence. Because I don't think we know what we're curing, much less what will work. And so I think it's going to be a lot of common sense. But I know I see parents all the time and say, look, we're going to try this. We know it's crazy. As long as it doesn't hurt the kid, I'll look over what they're going through. If there's something dangerous in that, I'll tell them. But I think a lot of people, it Bobby, it's easier to pursue that and then to come to their own conclusion. Because I think there's a lot of people that respond to any negative comment that you're just you're a physician, you're anti this kind of intervention. And so it's a lot of the larger psychosocial issue around the actual intervention. Sometimes it's the most interesting part of all of it.
I would say, from my perspective, one of the best examples of the desperation of parents and family members has been the whole vaccination drama that we just went through that was based on non-science and emotion more than anything. And I think the end result was that by far more harm was than good was done, other than it shed some light on the idea of we understand your desperation, but don't let it carry the day. Don't let it take you away from more evidence-based intervention.
But there were kids who had DPTs around 18 months or so, who had evidence of neurological disease, pertussis, whooping cough, who did react adversely. And I think this is what we have to sort of sort out, is the real cases from the background noise. And I think it got to be such a political hot-button issue, it stepped out of science realm and into the political and legal realm, which happens quite often.
Gentlemen, hi, Dr. Rudrick. Cheryl Vincent here, long time no see. I have two questions. One has to do with something I heard on National Public Radio as I was driving someplace that shocked me so much. I have a nephew who's Asperger's, and what his parents have done for him is absolutely phenomenal. Okay, they have tapped every state agency they could possibly tap. I heard a discussion that now the Asperger diagnoses are going up because there is some entity out there that is granting schools, dependent upon this diagnosis, $55,000 a year per child who's diagnosed. That really was shocking. So the one person said, oh, this was a very good thing, and I wanted to know what they were going to do in schools that was going to be so magnificent, okay? Because I don't believe today that I know very many school districts that have tons of child psychiatrists on board. Number one. Number two, where, if you remember, Dr. Rudy, at NPI, we had teams, of people, whether they were social workers, whether they were nurses, whether they were doctors, whether they were dietitians, whether they were physical therapists, et cetera. How does the team approach come in today in treating an autistic child? Today we've heard many things about, what's going on in the psychiatric world, but it almost takes a team because you gentlemen do not have enough time to spend with these children. So that's it.
Okay, well, I guess to the first one, I've not heard of any school spending $55,000 on kids with Asperger's, and I can't imagine that, I know it's not happening in Nebraska. And if it is happening in some other state, it's not going to last very long with the way state budgets are. To the issue of the team, we typically work as a team, have multiple individuals working with the kids, communicate with the schools, work with the parents. Parent training is a big part of what we do. And again, we talked about coordinating medication and behavior therapy interventions so that we know what's going on. And I would say that's right on target, is that this is something that no one discipline is going to be able to, these aren't problems that one discipline is going to solve.
Ohio is not doing that either. What is happening, and I'm not an expert in this area, but what's happening state by state is that many states are trying to figure out if they're going to legislate coverage for autism spectrum disorder treatment of children as a part of one's medical insurance. And some states have taken that step. That may be where you're getting that $5,500. There's clear evidence, I think, that early intervention helps for children with autism spectrum disorder. And so the question is, how do you pay for that? Should it be something that's funded with local property taxes through school systems from a state perspective? Should it be something that medical insurance covers? And this is really getting very dicey, because the Autism Speaks and Cure Autism Now group are actively promoting the notion that this should be something your medical insurance covers, and that's being kind of litigated and legislated state by state by state. To the other topic, teams work. If you've got a team, great, hang on to it. Multidisciplinary treatment is the only successful treatment.
John?
Okay, I work in the field with people with challenging behaviors and have for a lot longer than I'd like to mention. Psychiatric support is very important to what I do, and lately the Omaha area has lost at least 3 psychiatrists I know of, retirement or moving, and the search for a new psychiatrist to work with my population has resulted in some disasters. If you retire, I'm going back to construction. Is there a resource?
At first I thought you were going to blame me for these psychiatric disasters.
That's the next question. Is there a resource for identifying? We we go hunting for psychiatrists and we've had some disastrous results. Is there a resource that will help us identify somebody in our area that we might go to, that will, when I show them data,
Local.
know what it is?
Local, is that what you're talking about? Local psychiatry?
Yeah, so that we can, like, if you leave, what do I do? I mean, where do I go?
I was looking for my wife to see if we were leaving anytime soon. But, the quick answer is no. The local Nebraska Psychiatric Society is an option depending on the age of the individual. I think there may be more options for children and adolescents than adults. It is a shortage. People do leave. Medicine tends to be an itinerant profession to a degree. It's a problem. I don't relish being the only person around who wants to see everybody. There is something to be said for job security, but, you know. Jamie.
I was just going to say, I'm the training director for the Child and Adolescent Program, and we certainly have a goodly number of trainees right now, and we'll have 6 or 7 next year, I believe. So for the children at least, feel free to refer to either Creighton or UNMC, and our residents or myself or some of our other child faculty will be happy to help.
My caseload is 100% involved.
Right.
Kids don't come into our services anymore. They've got better support from being
Children grow up, and that's what seems to be forgotten in the mix.
And I guess
This is Dr. Baus, the Beacon's director.
Susan Baus from the Behavioral Health Education Center of Nebraska. And I guess my challenge is I am one of the mentees of Frank Mendelacino. Thank you to his family for sharing him so well. And I challenge us in Nebraska to address the issues raised by this panel of what is the right way to train psychiatrists to have the competencies that are necessary to meet the needs of this population, and that includes I'm sorry, Dr. Fisher, but your lecture, I consider myself a fairly right person, but it was so far over my head, and I'm like, are we practicing this in the same field? And yet we are. And so what is the right education for this interprofessional team that's going to meet the needs of our folks here in Nebraska? And if we can't do this here in the home of Frank Mendelacino, then I don't know where it's at.
Well, my quick answer is that Steve Rudrick hit it right on the head. The psychiatric establishment has been just blind and deaf and dumb to this need, and it's just kind of relied on the kindness of strangers to take care of this need. And perhaps a great goal for you and your organization would be to help develop that kind of model, and then disseminate that to other parts of the state. And Nebraska's not alone, but Jarrett and I were talking the other day in North Carolina. They finally figured out that adults need care too. It's the same issues, and there's not a real good model. There is no effective sort of referral system. You can call the different places. There was a guy at Emmanuel who was here for a while, and then he went to either California, Florida, or Hawaii. I'm not sure. I've heard all three. They went to nurse practitioners who didn't feel particularly comfortable. They've all been coming back. It's only made matters worse. It's difficult.
Sir, I don't have an easy answer to your question, but I will tell you this is not a problem unique to this state. It happens everywhere. The thing that gives me some hope is the Surgeon General's report, which has data showing that if you expose trainees early on in their experience, their clinical experience, to people with intellectual disability, it sticks. There's something very formative about having a normative experience with a person or persons or patients or next door neighbors who have intellectual disability. And so the long-range goal is to get that into the curricula of all the training systems, get it into the medical schools, get it into the social work schools, get it into the psychology departments, so that there are clinical experiences that are a normative part of one's development as a clinician. And you're much more likely, and there's data to support that if you've had that experience, you will at least be willing to see patients who have the dual diagnosis. It may not make it your full-time job, but it makes it easier. You've had some kind of normatizing experience with this. We have a collaboration that I think helps in my state, that we have a relationship where our County Board of Developmental Disability funds a residency rotation where our psychiatric residents go into the community, sheltered workshops and group homes, and do assessments in the field. And several of those people have decided not to make this a career, but to make it a part of their career. I think that's the best we can hope for right now.
Jamie?
I was just going to say, that whole silo model that you were talking about, I wonder if we crossed over a little bit between child psychiatry and adult psychiatry, that might not be helpful. I don't kick out kids when they turn 18 or 19 if I'm seeing them for developmental disabilities. My only challenge is I'm not as familiar with the adult services for these kids once they grow up. So perhaps as child psychiatrists, we see a fair number of these kids, but if we collaborated with our adult colleagues, perhaps we could develop something along those lines where we become more familiar with adult services and we help train adult psychiatrists that don't see a lot of these folks.
What's interesting in North Carolina is most of the people in North Carolina treating adults with disabilities are child psychiatrists. So we just naturally move up, and I think they're more attuned to teen approaches and more attuned to developmental disorders. But we have the opposite problem. We don't have any adult psychiatrists.
Does NADD have a listing of psychiatrists that have interest in this field?
No, not directly. I get that question a lot, and the best I can do is refer. It's usually a parent. I need a psychiatrist in Topeka, Kansas. Is I will refer them to NAD members in Topeka, Kansas, who then they could network and find somebody. But as Steve was saying, there's a shortage all over the country. I'd like to challenge the schools like the University of Nebraska and Creighton University to start looking at the possibility of offering some seminars on a regular basis on this subject area, leading towards more, maybe more loftier goals of maybe doing a residency or something like that, or a fellowship. But I would like to challenge, since I have Dr. Wilson's attention, to and as well as the University of Nebraska, to look at this issue to see, is there something you can do in your department that could help stimulate further training of your students to get them some level of information about developmental intellectual disabilities, at least some baseline information, so they have some level of understanding and comfort. And as Steve said a couple of times, once a psychiatrist, true with other disciplines too, are exposed to working with people with intellectual developmental disabilities, then they're more likely to like working with people with intellectual and developmental disabilities, because they've gotten beyond what I consider the fear factor.
I think we certainly can do it, and I was very taken with your reference to how the exposure influences career interest down the road. And obviously this is the place that should be offering leadership in memory not only of Dr. Mendocino, but to continue that work. We have a number of, I mean, my mind is already working. I know Susan and Mark. We could pull a lot more together, and it could become increasingly formalized and grand over time. So it's not a challenge, it's an opportunity.
I like that. Thank you.
Scott?
Yeah, I had a question.
Would you, Shelley, would you allow your brother?
Sit down, Shelley. No, I had a question for you. You've talked about exposure might breed practice. And Steve, I was interested to hear how much more practice or exposure there is in the United Kingdom to the psychiatrists and training with mental retardation. I guess my question is, because I don't know, in the United Kingdom, are they practicing dual diagnosis?
Yeah, it's a whole specialty. So when a doctor wants to be...
Mike, please.
Well, the question is in the UK, it's a specialized field. So people who enter that field have usually an exclusive practice in providing psychiatric services for people with intellectual developmental disabilities. And that the population that they serve go to certain centers, the Mick and Broader buildings, that service individuals who have intellectual developmental disabilities or dual diagnosis. So they're trained and it's specialized, so the social workers, psychologists, and other allied professionals are trained and also work in kind of a team approach, analogous to what we in our country with child psychiatry, where you work kind of a more holistic kind of approach, and so is true with the services in Europe. In the UK.
And in that system, if you are educated up to the point of being a senior registrar in their system, because you work for the National Health Service, that's all you do. You don't have the option particularly of saying, well, I'm going to do this on Monday and something else on Tuesday and something else on Wednesday. So those senior consultants or senior registrars are full-time in the job. They've been educated by the system to do that, and they're responsible for for provision of services within their catchment area. We have a much, much more fragmented system of both training and treatment, so that we're a few light years behind them in this area.
We have time for one more question, and then I insist on a closing.
There was a parent that gave a written question. Can I go ahead? Okay. It says, please refer a good summer program for a 12-year-old boy with Asperger. We have a couple of programs at MMI. One is our rec therapy program that runs camps during the summer. That's just geared towards having fun, so that would be a very reasonable option. And then there is a social skills training group for this age range, and I believe that there'll be a group starting in July for that.
I just had a couple quick questions. How common is it for twins to have autism? And I think I read something where it was 1 in 200 kids have it. And if that's the case, wouldn't it be a lot higher in the numbers?
Actually, if you look at what's called concordance, it depends on whether you're monozygotic, which means identical twins, versus dizygotic fraternal twins, which are very much like siblings. But it approaches 50% if you take the spectrum of language disorders, social behavioral difficulties, it gets up to 90%. It's extremely high. And that's why it got people so interested in this idea that this is a genetic disorder and that it has a spectrum that there may be other symptoms associated with it that are genetically related to it that might not be hardcore autism, but something else. And so, but it's extremely high. 90%. I think that if you take autism with Asperger's, with PDD, with this broad expanded phenotype, it's enormous. And routinely just autism would be about 50%.
My turn then. So we do have to wrap this up. There are a lot of people to thank. I think Shelley, first of all, who's been really I hesitate to use the word manic, but certainly obsessed comes to mind. Focused, driven to make this work when a lot of us were looking for something more focused and smaller, and she said, nah. And I think it's been successful. We're completely filled up upstairs. We filled this room down here. This was a great start. The people who wanted us to be successful, I think, would be delighted. I want to thank the people who are here today for delivering the goods. I mean, they really did, I think, enlighten a lot of people. And looking to the future, I think only bigger and better things for the community and for the people that we hope to serve. So I want to thank you all for coming.